these unacceptable realities. So, without further ado, I will introduce our first speaker, Dr. Sean Blackwell. Dr. Sean Blackwell is a professor and chair of the Department of Obstetrics and Gynecology and Reproductive Sciences at McGovern Medical School, formerly University of Texas Health Science Center at Houston. Dr. Blackwell completed his undergraduate degree as a double major in the classics and biology. Forgive me if I pronounce this wrong, Wabash College in Crawfordsville, Indiana. He matriculated medical school at the University of Illinois College of Medicine in 1993 and completed both his obstetrics and gynecology residency and maternal fetal medicine fellowship at Wayne State University in Detroit, Michigan. He joined UT Health in 2007 and also serves as the director of the Larry C. Gilstrap MD Center for Perinatal and Women's Health Research and as an assistant dean for healthcare quality in perinatal medicine and women's health. Dr. Blackwell is the chief of service for obstetrics and gynecology for Children's Memorial Hermann Hospital, Texas Medical Center. And in 2014, Dr. Blackwell earned his Six Sigma Lean Black Belt at the University of Houston. And I should also add, Dr. Blackwell is the most recently elected president for the Society for Maternal Fetal Medicine. So please welcome Dr. Sean Blackwell.
Alrighty, well, it's definitely a pleasure to be here and share this topic with everyone. I mean, one of the very positive things for me to be able to hear is if there's going to be change and improvement in this area, you all are going to be the folks that do it. I'm going to be somebody that's going to go to a lot of meetings, talk a lot, but the reality is you all are going to be the ones that are going to carry out and make a difference 5 years, 10 years, 20 years. This is not something that's going to go away in a matter of months. It's a timeline that's very different. So I was asked to really kind of talk and set the stage in presenting some data. I think it's really important that we have our passion, we have our mission to help women and children to have safe childbirth and healthy lives, but at the same time, we as physicians are scientists, and we need to be data-driven if we're going to take evidence-based practices towards changing things and making improvements. Let me see here. All right, so real briefly, I'm probably going to spend 15 minutes or so talking a little bit about how is mortality and pregnancy-related deaths defined, what's the frequency, talk a little epidemiology, and some key risk factors, again, to set the stage for some of the other discussions that are going to be here, and kind of give a little bit of feedback on how we're looking at this now as a strategy to go forward to make some changes. Because there are limited resources in everything that we do. We have to make choices. We can't do everything that we want to, unfortunately, so we have to be strategic in what we do. One of the most important things to get started off on the right foot is making sure you're defining things the same. And in this category, things are a little bit all over the place, and it makes it hard to look at numbers and say, we can say internally numbers are changing over time, but when we compare ourselves to other countries or to other states, you got to make sure things are the same. Maternal mortality is death. Death is bad. We want 0 deaths. But also, we want to focus in on pregnancy-associated conditions. And we talk to obstetricians and maternal fetal medicine specialists like us. This is a really important distinction because there are some things that we can control. You know, we can control childbirth to a certain degree that happens here in the United States in the hospital a lot and manage that. But there's a heck of a lot of death that's occurring unrelated to pregnancy that are societal issues that need to be tackled with different solutions. And we'll talk a little bit about that. If you go to the CDC, and the CDC has wonderful information about state differences and national changes over time, they really focus in on pregnancy-related deaths. And again, to a certain degree, this is a hard thing because you have to have enough clinical information to say it's pregnancy-related or not. And oftentimes, birth and death certificates have administrative data on them, And it's not chart review data. It's not like what we're used to when we're in the hospital taking care of patients or looking at prenatal records when you have really good details. You're looking at billing data and other things, and that can make it very, very challenging when you're looking at that to make a decision of a cause of death as well as whether or not that cause was related to pregnancy. So the CDC oftentimes uses pregnancy-related deaths, and now they've migrated towards within a year post-delivery. And again, this is something that's changed a little bit, the vernacular over time. When we at times look at 42 days post-delivery, that was 6 weeks postpartum. That was kind of arbitrary historically, how they picked 6 weeks to say that it would be specifically related towards the delivery process. But now we're moving towards a year, which is a good thing. The WHO uses a little bit different definition, and this is where you've always got to kind of go to the footnote whenever you see data in a graph to go back and forth to make sure that you're comparing apples to apples. And in particular, you want to look, number one, is it pregnancy related or not? And number two, what's the time frame? Is it 42 days? Is it a year? Is it longer? And then the source of the data. Again, is it birth and death certificate data? Is it clinical data? Is it maternal mortality review data? What it is? Because it all drives that. If I start big picture looking at the United States, looking at the world, 99% of all maternal deaths occur in developing countries. It's a tragedy. It's a crisis. It's certainly gotten a lot better with just very basic access to basic care in many areas. But the reality is the risk is so much higher in developing countries. When you look at developed countries, it's 12 per 100,000 births. In developing countries, it's 239, and that's 2015 data from the WHO. The other thing that you focus in on when you're looking at a world approach, especially in developing countries, the majority of deaths are specifically related to the childbirth process. Again, I'm going to show you a little bit differences in what we're seeing here in Texas, but that's hemorrhage and bleeding, that's sepsis, that's eclampsia, that's stroke, that's unsafe termination procedures. Those are things that are more related to the birth process itself. In the United States, the overwhelming majority of births are in the hospital. That in itself pre-selects a significant difference of safety. When you take a look at maternal mortality and you look at it at a state level, we in Texas, we're in a bad color here. Certainly when you look across any state maps, you're looking at sicker populations. There's definite trends that you can see. If you overlay the percentage of women that are obese or morbidly obese, it's the same colors. If you take a look at the percentage of women that are having babies greater than 35 or 40, it would be the same colors. If you're taking a look at the frequency of the rise in diabetes and metabolic syndrome or chronic hypertension, you see the same things. Okay, so but this is where we're at when we try to compare ourselves to other states. I'm not sure how useful it is to compare mortality to Maine when you're in Texas, or to California for that matter. So I think we've got to be strategic in the way we take a look at things. So this is data from the CDC. The most updated data is up to 2013. And again, this is trends in pregnancy-related mortality. So what percentage of all maternal deaths within a year are pregnancy-related versus other causes? Not clear, but it's at least 50%. Okay, so if you're just trying to very raw look at numbers, about half of maternal deaths may be related to other things. The other half are related to pregnancy. So there's no doubt, I don't think anybody should try to argue that the numbers aren't increasing and aren't going in the wrong direction. So again, just looking at it, again, it depends on what you're going to compare yourselves to. If we're going to compare ourselves to the 1990s, there's definitely a difference, or the 1980s. If we're going to compare ourselves to 3 months ago, you're not going to necessarily see those temporal trends. So this is the McDormand paper that got all of us that live in Texas pretty cranky, right? So, and there's lots of issues with this. You could sit here and spend an hour talking about the limitations of this analysis, how we clinicians don't really like epidemiologists, all the sorts of things that you can pull out of here. But the data is the data, and there are themes within this. It was published in the Green Journal back in 2016, and this is really what triggered the majority of the national attention towards Texas and maternal mortality. There were some other things going on with other advocacy from the Society of Maternal Fetal Medicine and ACOG, but this is what got NPR, got ProPublica, got the New York Times, got other reporters thinking about it. So you take a look on the left-hand side, it's the estimated maternal mortality rates, and you see changes just over a decade, a decade plus. And then on the right-hand side is the slide specific to Texas. And again, it's adjusted maternal mortality rates. There's lots of issues with the way this data was collected and changed over time. There probably was not this massive crisis of a tsunami of deaths all of a sudden over a year or two. There's definitely trends going in the wrong direction. If you want to talk about that, we can talk about the other parts of how that data was collected later. I think the other key things to think about is what's causing the deaths. Because this is, again, we have to be strategic on what we can control and what we can't, and what are our targetings. So if you take a look at all across pregnancy-related deaths in the United States, about 6% have unknown causes, which is really pretty low. If you take a look at other areas, it may be as high as 30%. You don't have a good cause of death in a lot of patients. And again, it depends on what's your level of certainty. If you want to be really, really certain about the cause of death, you're going to have a much higher rate of unknown. But if you take a look here, cardiovascular disease, other medical disorders, infection, hemorrhage, cardiomyopathy, PEs, hypertension, these are all things that happen in the hospital or right around childbirth usually. So again, if you see all of the things that have been done in hospitals, having a doctor in the hospital, a hospitalist model, right there, right off the bat, there's a lot of potential benefit. Access to prenatal care, having hospitals be in rural areas, having protocols, having blood banks, having access of transfer systems and those sorts of things. Those are kind of things that all go towards hospital-related deaths. This is, I think, a slide that's important as well. It's gotten a lot of attention. It's a little hard for you all probably to see, but it's the relationship between the cause of death and changes over time. All right. So, and this goes from the really early 1990s up to the 2010s and beyond. And it's really the big picture of what's going up and what's going down over that time is what matters. If you take a look at hemorrhage, it's really gone down a little bit. And that's probably because of all the care that's happened within the hospital. If you take a look at hypertension, again, that's probably related to better prenatal care as well as better hospital care. Infection, pretty standard. And again, we're here in the United States. If you get access to care, your frequency of sepsis related to childbirth is really pretty low. Again, compared to developing countries. Your PE has gone down. Anesthesia complications definitely down. Again, these are all hospital things. If you take a look at some of the trends that we see with the sickness of our patient population, that's going the other direction. That's at the other end of the bar. So cardiovascular conditions, cardiomyopathy, CVAs, these are related to obesity, diabetes, metabolic syndrome. It's the sickness and the age of our patients getting pregnant later and being sicker when they're pregnant. So that's going in that direction. So that's one theme. The other theme are the racial and ethnic disparities related towards maternal deaths. This is data from the state of Texas, and it shows the breakdown of race and ethnicity for all maternal deaths on the left-hand side, and just looking at births on the right-hand side. Much higher percentage of women, African American and Hispanic, having maternal deaths. This is the other key thing here about age. Again, seems pretty straightforward. The older our patients are getting, the higher mortality rates there are. You see big thresholds when you're getting over 40 years old. You're certainly seeing it in our infertility population that are going through the IVF process, our 40s to 50s, and then on top of it have underlying medical conditions. If you're really interested, I'm going to point you towards a couple things to look at. There was the maternal mortality task force report. You can get this online. It's not that long. It's got some interesting data. There's some thoughts to learn from it. I would tell you it's really chapter 1. It's a very superficial look at where we are with maternal mortality. And the task force, that's one of their take-home messages. The other, if you're really interested in the compelling story about the epidemiology of the changes in maternal deaths in Texas, this is a really nice review. It was published in the American Journal of Pregnancyrelated by several of the people that are on the task force, and it really kind of gets to the argument of what's changed over time. Was it a change in the way we collected information about deaths, or was it a true phenomenon of change? And I've got a little bit of data. This overlays the concept. On the x-axis is time. On the far y-axis is the maternal mortality rate. Again, this is not pregnancy related. This is everybody. And then the right-hand side, it's the straight percentages. If you take a look at the change in obesity, the change in hypertension and diabetes, these all go in the same direction of the changes in the maternal mortality rate for the state of Texas for all women over time. Okay? Again, it's a theme. If you take a look at our underserved populations, it's even more pronounced with the relationship between hypertension, diabetes, maternal weight changes, and the maternal mortality rates, especially in our African American population. This is another key thing that you'll hear somebody like me talk about. I try, when I get into issues related towards maternal mortality, focusing on pregnancy-related and non-pregnancy related. So cardiac events, hypertension, eclampsia, hemorrhage, sepsis, I would all argue those are much more commonly hospital-related and childbirth-related. But when you look at data, and this is again data from the state of Texas, from what the task force put together, a lot of us, when we saw this, said, oh my goodness, we're in a new world. We're in a different state of problem. The frequency of drug overdose, homicide, suicide in women as their cause of their death up to a year of life caught a lot of people's attention. This isn't something that we think about in maternal fetal medicine a lot, and this is a crisis of a problem. Even though it's not related to childbirth, it's a major contributor to death, and we've got to figure out how to solve this. And again, it's a very different strategy than dealing with the hospital. The other really key thing is on when are these women dying. And again, on the x-axis, it's the days elapsed between death and delivery. On the y-axis, it's the percentages. So remember I said 6 weeks postpartum, that's kind of when, in our traditional pregnancy land, we think of the postpartum period. This is the difference on how you capture things. So if you're trying to capture deaths all the way up to a year, greater than 60% of the deaths occurred after the 6 weeks postpartum. They are probably related, they haven't teased into the data, but this is the suicide, the homicide, the drug overdose, and then the women with chronic medical conditions that don't have access to care. Pregnancy tends to be a really good thing for a lot of women that don't have access to care because they're able to see a doctor. They're able to get medications. They oftentimes get tuned up. You can't, we oftentimes talk about, the trifecta in pregnancy, which is a woman with morbid obesity, hypertension, and diabetes. You can't, in a period of pregnancy, because oftentimes they're not going to be able to have access until they're halfway through, somewhere between 10 and 20 weeks. We can only tune them up. We can only kind of stabilize them. You can't fix anybody in the time period of pregnancy. And there are some benefits now where people are being covered up to a year of life. It's unclear what percentage of our overall patients are going to be able to qualify for that, but even a year is kind of short when you're talking about these really sick patients. So I've got three slides of just observations as people kind of dig in how to talk about this. So I don't think anybody that's being thoughtful would say that mortality hasn't increased. So we just got to own it. We have, when you have a problem, step one is admit that you have a problem. We have a problem here in Texas. I think that a lot of the problem is related to non-pregnancy related conditions. When I say non-pregnancy, non-childbirth related. The interplay of mental health and pregnancy and the postpartum state is very complicated, but but it's not the traditional bleeding, stroke, preeclampsia that we're talking about. Next is a large percentage of these deaths occur outside of our traditional postpartum window. They're not occurring within the hospital when we can hold on to people. They're occurring in patients oftentimes that aren't seeing doctors anymore or don't have access. There's tremendous disparities. The data all shows that our patients are getting sicker. They're not getting healthier, they're getting sicker. So we've got to figure out what we can do about that. I think that the last thing to take home on is just these other factors. And again, this is probably going to come from people outside of my expertise, right? How to manage mental health, how to get access of resources to patients going through drugs or alcohol or other types of addiction, severe postpartum hemorrhage, or just the underlying rate of depression and mental health in women that are coexistent when they have pregnancy. Sometimes it gets worse, oftentimes because we take them off their medications or they self-stop them because of the fear related towards their children. It's all interrelated. But as an MFM specialist, when I think about how do we tackle this problem, these are some of the things that I try to put them into different categories to empower that discussions on solutions. I mean, I think there's a lot of efforts about what's going on, why it's going on, but we're getting to the point of what the heck are we going to do about it? That's really hard because you got to be strategic. There's very limited resources, and it's not a quick fix. There's definitely not a quick fix that's interplay with, especially with these society things. So with that, I'm going to stop and go on to next things, or what do you want to do?
So we can take maybe 2 minutes for questions, if anybody has any questions for Dr. Blackwell specifically.
What was VTE in the last slide you showed?
What was that?
VTE, what does that stand for?
Oh, here you go. Venous thromboembolism. So that's DVTs or PEs. You know how we have to have a million abbreviations. It's impossible for us to not do that.
Could you comment on if we had Medicaid expansion in Texas, how that might impact these numbers?
A little bit outside of my area of expertise, but I definitely think that even if we expand, the good thing is in pregnancy, everybody can get care.
But that year after?
But that year after, for our sickest of our sick, for the sickest of our sick population, I think it's tremendously important. Or I think it's tremendously important for women. that have mental health issues. So if I looked at severe chronic morbidity health, which is a smaller percentage, but when you take a look at their utilization of healthcare services, their morbidity is super high, right? So we did, just to get off topic a little bit, again, talk towards the business argument for doing this, which is what the majority of people respond to anymore. Whether you're talking to the legislature or hospital systems or payers, it's not necessarily about the patient, it's about the business model. And I'm okay with that being part of it. But we've done a pilot of bundled care with one of the payers, and when we looked at all the costs related towards what it is that we're doing, and 50% of the cost came from 5% of the population. And that's probably that's that group of people that are the sickest of the sick and need the year before and certainly the year after. So bad diabetes, bad hypertension, bariatric problems, mental health, if I had to pick them.
Last question.
Thank you so much for your presentation. So you identified old age as a risk factor for maternal mortality, or was you wondering what about young age, like teenage?
Yeah, there's definitely a spike if you're, it depends on what you define as young. If you define 14 and younger, definitely there's a spike. If you're looking between 16 and 20, not so much, as long as they have access to care.
Thank you so much, Dr.
Thank you.